Picture this. An emergency room. A patient wheeled in, clutching their chest, drenched in sweat, their ECG practically screaming danger. It's a race against the clock, a moment of stark truth. But the real question, the one that truly unravels the mystery, isn't just about the immediate crisis unfolding before us. It's how did we even get here?
Yeah.
What set the stage for this life-threatening event?
Today, we're not just looking at a diagnosis. We're going on a deep dive, journeying back in time, often decades, to understand the foundational steps of coronary artery disease.
Right.
Our mission is to truly master the early pathogenesis of atherosclerosis, that silent, insidious process that leads to heart attacks.
Right.
We want to dissect every detail, tracing the very first domino to fall on a cascade that can culminate in something as dramatic as our patient's crisis.
And you, our listener, you've given us a fascinating case to explore, a perfect lens to really unpack these underlying mechanisms. We're going to walk through it step by step, not just to find the single initial step in this journey, but to understand why it's the right answer. And perhaps more importantly, why other common ideas, though crucial to the disease, aren't where it all begins. This is our collaborative exploration, and we want to deliver those aha moments that make complex biology crystal clear so you walk away truly well-informed. So, let's set the scene with our clinical picture. We have a 61-year-old woman, rushed to the emergency department. She's in clear distress, presenting with classic severe symptoms of an acute cardiac event, crushing substernal chest pain. And it's been going on for 2 hours, starting while she was at rest. That at-rest detail is incredibly significant, isn't it?
It absolutely is. When chest pain, especially this severe crushing type, occurs at rest, it immediately signals a critical problem. It tells us that her heart muscle isn't getting enough oxygen even when its demands are, well, at their lowest,
right,
suggesting an unstable form of angina or, more likely, an acute myocardial infarction, a heart attack. Her body's under extreme duress, evidenced by the diaphoresis, profuse sweating, a common physiological response to such intense pain and stress.
And her vital signs give us a snapshot of this distress. Her temperature is mildly elevated at 37.5 degrees or 99.5 degrees Fahrenheit.
Okay.
Her pulse is 110 beats per minute, which is fast, and her respirations are slightly elevated at 21 breaths per minute.
Tachycardia, yeah.
Her blood pressure is 11,565 mmHg, which is, well, within normal limits.
These vital signs reinforce the picture of a body under stress. That mild temperature elevation could be an early systemic inflammatory response or just her body reacting to severe pain.
Makes sense.
The elevated pulse, tachycardia, is her heart working harder to compensate, trying to get enough blood to deprived areas. Elevated respirations could be anxiety or, in a more concerning scenario, an early sign of fluid backing up into the lungs if her heart's pumping efficiency is declining.
Okay.
And that blood pressure, while appearing normal, can sometimes be misleading in an acute event. It might be masking an underlying issue, with her body's compensatory mechanisms briefly maintaining it. Together, they paint a picture of a system in crisis.
The diagnostic clues really sharpen the focus on her heart. Her ECG, the electrocardiogram, shows ST elevation in leads I, AVL, and V2, V4.
Ah, this is a direct urgent signal. ST elevation on an ECG is the definitive hallmark of an ST elevation myocardial infarction, or STEMI.
STEMI, right.
It means there's acute myocardial injury happening right now. Heart muscle cells are being damaged due to a severe lack of blood flow.
Okay.
The specific leads involved, I, AVL, and V2, V4, tell us precisely where this damage is occurring. The lateral and anterior walls of the left ventricle. This points to a significant anterior lateral heart attack, typically caused by a major coronary artery occlusion.
And the culprit, confirmed by coronary angiography, is an 80% stenosis in her left anterior descending, or LAD, artery.
The LAD artery, yeah, it's often grimly called the widowmaker because it supplies blood to such a large and critical area of the heart, specifically the anterior 2/3 of the interventricular septum and a significant portion of the left ventricle's anterior wall.
The main pump.
The heart's primary pumping chamber, exactly. And 80% stenosis means this artery is severely narrowed, almost completely blocked. This high-grade narrowing is the anatomical basis for her acute chest pain and MI. It's the physical blockage, the culprit lesion, that directly caused her acute symptoms by choking off blood flow to a vital part of her heart.
So we have a clear, devastating picture of a crisis, the dramatic result of a problem. But the real mystery you asked us to unravel is, how did this 80% stenosis, this widowmaker blockage, even begin? What was the very first step in this long, silent journey that culminated in such a sudden, acute heart attack? Many factors are involved in heart disease, cholesterol, inflammation, plaque, but what's the absolute starting gun?
That's precisely the core question here. And it's a great one because many common ideas about heart disease like blocked arteries, inflammation, or cholesterol are indeed crucial pieces of the puzzle. They're vital components of the progression, but they aren't the absolute beginning. Understanding the precise sequence is everything to grasp the pathogenesis, and critically, it's a point where many people can get confused. They might correctly identify a factor as part of atherosclerosis, but mistake it for the initial trigger.
And for our listener aiming to master this information, understanding that distinction, what's the initial trigger versus what's a crucial subsequent step, is key to truly grasping the disease and for, let's say, acing any challenging questions thrown your way.
Absolutely.
So let's cut to the chase. The most likely initial step and the correct answer here is endothelial cell dysfunction, option E.
Exactly. This is the cornerstone of understanding atherogenesis. Endothelial cell dysfunction describes a state where the endothelium, that delicate single-cell inner lining of our blood vessels, loses its normal healthy protective functions.
The lining itself.
Yes, the lining itself. Normally, a healthy endothelium is like a perfect non-stick coating on a pan. It's anti-inflammatory, prevents blood clots, and produces substances like nitric oxide that keep vessels open and blood flowing smoothly.
Keeps things moving.
Right. When it becomes dysfunctional, it essentially flips these roles.
Yeah.
It becomes sticky, pro-inflammatory, prothrombotic, and critically more permeable, meaning things can get through it that shouldn't.
So it's not necessarily a physical rip or tear in the artery lining, but a functional impairment. It stops doing its job properly.
Precisely. Think of it as the initial crack in a dam. It might seem small, almost imperceptible, but it compromises the entire structure, setting the stage for all the dramatic events that follow.
That's a great analogy.
This is the fundamental, earliest event that makes the vessel wall vulnerable, initiating the entire inflammatory and lipid deposition cascade. Without this initial impairment, the subsequent steps, which we'll definitely get into, cannot efficiently occur.
Okay, so if that's the starting point, what causes this critical dysfunction? What are these chronic external factors that start to damage this delicate lining over time?
Well, a host of well-known cardiovascular risk factors are the culprits. Hypertension or high blood pressure subjects the vessel wall to abnormal shear stress.
Like wear and tear.
Exactly. Constantly battering those delicate endothelial cells like a river eroding its banks. Smoking introduces a cocktail of toxic chemicals that directly harm endothelial cells, generating significant oxidative stress.
Rusty stuff.
Very nasty. In patients with diabetes, advanced glycation end products, or AGs, contribute significantly to oxidative stress and inflammation, directly damaging endothelial cells. And while LDL infiltration comes later, dyslipidemia, especially high levels of circulating low-density lipoprotein, or LDL, contributes to chronic endothelial stress and damage.
The bad cholesterol.
That's the one.
Yeah.
It puts those cells under constant pressure. Finally, chronic inflammation from various systemic sources can also directly impact endothelial health, keeping those cells in a state of activation and vulnerability.
So this is the very first domino. Endothelial dysfunction. Now that we've found the starting line, let's follow the race. We have an incredibly insightful diagram in our sources that will be our guide, showing us how decades of silent changes can culminate in minutes of crisis.
Let's do it.
This is the full journey, from dysfunction to thrombus, a deep dive into atherogenesis. As we walk through these stages, we'll see exactly where those other options from our initial question fit in and why they aren't the true beginning.
Let's unfold this story step by step, starting with the baseline.
Stage 1. Normal endothelium. This is our healthy baseline, where we want our arteries to be nice and smooth.
Absolutely. In a healthy state, the endothelium is perfectly smooth, physiologically air permeable to large molecules, and actively works to prevent blood clotting. It's a dynamic organ, not just a passive lining.
Right, it's active.
Constantly releasing substances that keep blood flowing freely and regulating the tone of the vessel. It's our body's exquisite first line of defense against arterial disease, a true gatekeeper.
But then, due to those chronic stressors we just talked about, smoking, high blood pressure, etc., we enter stage 2, endothelial cell dysfunction. This is our crucial initial step.
Correct. This is where those chronic stressors begin to compromise the endothelial cells. It's not a physical tear, remember, but a functional impairment. The cells become activated or stressed.
Okay.
They start to express specific adhesion molecules on their surface, like VSAM1 and ICAM1. Think of these as sticky patches appearing on the normally smooth, non-adherent vessel wall.
Like Velcro patches.
Sort of, yeah. This makes the endothelium more attractive to circulating immune cells. They also begin releasing inflammatory signals, called chemokines and cytokines, that act like a beacon for other immune cells.
Calling them in.
Exactly. And critically, their permeability increases, allowing things that shouldn't easily pass through to begin entering the vessel wall. This stage can subtly begin as early as childhood and is largely clinically silent, with no noticeable symptoms.
Wow, childhood. Okay, which brings us to stage 3, infiltration of LDL and monocytes. This is where some of those other options start to come into play.
Precisely. With that increased endothelial permeability from stage 2, low-density lipoprotein, or LDL particles, especially if circulating levels are high, can now easily penetrate this compromised endothelium and begin to accumulate in the subendothelial space, the intima.
They sneak in.
They get trapped within the arterial wall.
Uh-huh.
At the same time, those inflammatory signals and adhesion molecules that appeared on the dysfunctional endothelium act like magnets, attracting circulating monocytes, a type of white blood cell.
Immune cells.
Right. These monocytes adhere to the now activated endothelial cells. Following a chemical gradient, they then emigrate or squeeze through the endothelial layer and into the intima, the subendothelial space. Once they're there, they undergo a crucial transformation, differentiating into macrophages.
So the monocyte infiltration mentioned in option B, intimal monocyte infiltration, isn't the initial step because the endothelium first needs to be dysfunctional to allow that infiltration. It needs to be sticky and leaky first.
Exactly. You've got it. Option B describes the first step in the immune response within the artery wall, but it's a consequence of the preceding endothelial dysfunction. The endothelium must first become permeable and express adhesion molecules to allow monocytes to stick and then emigrate. This is a critical distinction. What enables the first cellular event is the dysfunction itself.
Got it. And something else critical happens to that LDL once it's inside the artery wall, right? It doesn't just sit there.
No, it doesn't. Another vital detail in stage 3, those LDL particles that have now infiltrated the subendothelial space become oxidized by reactive oxygen species present within the arterial wall. This oxidized LDL, or ox-LDL, is extremely pro-inflammatory.
Bad news.
Very bad news. And it acts as a potent chemoattractant, further drawing more immune cells to the area. It fuels the fire.
So LDL oxidation, option D, occurs here. It's hugely important for the process, but again, it's not the initial step because the LDL first has to get into the artery wall, which requires the dysfunction.
Yes.
And then it gets oxidized.
That's spot on. Option D, LDL oxidation, is critical for the disease progression, particularly for macrophage activation. But it happens after LDL has infiltrated the intima, which itself depends on endothelial dysfunction. So, while high-circulating LDL is a major risk factor for causing endothelial dysfunction initially, the oxidation of LDL is a subsequent event that occurs once the LDL is already trapped and altered within the vessel wall.
Okay, the sequence is really key here. So now we have macrophages and oxidized LDL in the intima. This sets the stage for stage 4, foam cell formation resulting in fatty streaks. This brings us to option F.
Absolutely. The newly differentiated macrophages in the intima have a voracious appetite for that oxidized LDL to become like ravenous vacuum cleaners for it.
Hoovering it up.
Exactly. Unlike normal LDL receptors on other cells, which downregulate when cholesterol levels are high, the specialized scavenger receptors on these macrophages are unregulated.
Unregulated.
Meaning they just keep hoovering up ox-LDL. They don't have an off switch in the same way. They keep going until they become engorged with lipids. When you look at them under a microscope, they appear foamy due to all the lipid droplets.
Ah, hence foam cells.
Hence the name foam cells.
Exactly. And the accumulation of these foam cells creates what we call fatty streaks.
Precisely. The accumulation of these foam cells, along with some extracellular lipid and cholesterol crystals, creates what are known as fatty streaks. Think of them like tiny yellowish smudges on the inner artery wall. They are indeed the earliest visible histological lesions of atherosclerosis.
Visible lesions, okay.
These can even be found in children and young adults, which often leads people to mistakenly identify them as the initial step in the pathogenesis.
Ah, the first visible trap. Because you can see it, you think it's the start.
That's the trap. But again, it's not the true initial step because it's a consequence of everything that happened before.
Yeah.
Dysfunction,
Yeah.
LDL infiltration, LDL oxidation, and monocyte transformation into macrophages.
Right.
So option F, intimal foam cell accumulation, is a key visible milestone, but not the start of the process. It's a result, not the cause.
You've nailed that crucial distinction. Endothelial dysfunction is the initial pathogenic event, the true biological trigger. Fatty streaks are the first visible manifestation. This is a common pitfall, confusing the first sign with the fundamental cause.
And it's so important for prevention, as we'll discuss.
Right. Importantly, stages 2 through 4 are still largely clinically silent, occurring over decades without the patient ever knowing they have this insidious process unfolding within their arteries.
Decades. It's quite sobering.
It really is. Next, we have stage 5, proliferation and migration of smooth muscle cells, SMCs, and ECM deposition. This relates directly back to one of our initial incorrect options, option A.
Correct. At this stage, smooth muscle cells, or SMCs, which are normally found minding their own business in the media, the middle layer of the vessel wall, begin to migrate into the intima.
They move how?
They do. This migration is stimulated by powerful chemical sigils, often called growth factors, like platelet-derived growth factor, PDGF, and fibroblast growth factor, FGF,
Okay.
which are released by activated macrophages, platelets, and endothelial cells that are already present in the area, participating in that inflammatory milieu.
So it's a response to the existing inflammation.
Exactly. Once in the intimae, these SMCs don't just move in, they also proliferate, meaning they multiply, adding to the growing bulk of the lesion. Simultaneously, these migrating and proliferating SMCs begin to synthesize and deposit large amounts of extracellular matrix, or ECM.
Stuff like collagen.
Yes, including collagen, elastin, and proteoglycans. This ECM production is a significant component of the growing lesion, giving it structural integrity and adding significantly to its volume. It's bulking up.
So option A, intimal smooth muscle cell migration, is certainly a crucial event in plaque development, but it occurs much later in the sequence after the initial endothelial damage, inflammation, and foam cell formation. It's a response to prior injury and inflammation, not the initial trigger.
Precisely. It's part of the plaque progression and later stabilization, contributing to its structure and growth, but it comes well after the initial inflammatory and lipid deposition events. This differentiation is important because while SMCs are major players in the later stages, they aren't initiating the entire process.
Okay. As this process continues, we reach stage 6, fibrous plaque formation. This links to another one of our initial options, option G.
Indeed. This is where the lesion matures into a well-defined atherosclerotic plaque. It's characterized by distinct and complex structure. It features a dense protective fibrous cap.
The cap on top.
Right, composed primarily of those smooth muscle cells and the extracellular matrix they produced, collagen, elastin, and proteoglycans. This cap overlies a necrotic center, or lipid core.
The nasty stuff underneath.
Exactly, which is a highly inflammatory and unstable region containing dead foam cells, extracellular lipid, cholesterol crystals, and cellular debris. The presence of macrophages and lymphocytes in the cap and core indicates ongoing inflammation within the plaque itself.
So, option G, fibrous plaque formation, is clearly a much later, more advanced stage of the disease, the culmination of all the preceding steps, not the beginning.
Exactly. It's the result of decades of disease progression, a complex interplay of cells and molecules. This fully formed fibrous plaque is the very structure that can eventually grow to obstruct blood flow or, more dangerously, rupture. Understanding that plaque isn't the primary disease itself, but an advanced symptom or lesion resulting from a long unfolding series of earlier events is a critical distinction.
Okay. As the plaque continues to grow and mature, it becomes clinically significant in stage 7, obstructive plaque. This is where the patient might start feeling something.
This is often where the silent disease finally starts to announce itself, yes. Continued growth of the plaque leads to significant narrowing or stenosis of the arterial lumen. When this narrowing becomes substantial enough, blood flow can become insufficient to meet the metabolic demands of the downstream heart muscle, especially during exertion.
Like climbing stairs.
Exactly. This can cause symptoms like stable angina, which is chest pain that occurs reliably with exertion and is typically relieved by rest. In severe cases, like the 80% stenosis we saw in our patient's LED artery, the narrowing can be so profound that it causes symptoms even at rest or with minimal exertion.
Like our patient.
Like our patient. Her 80% LED stenosis is a clear example of an obstructive plaque, setting the stage for crisis. This stage is no longer silent. It's starting to speak volumes, unfortunately.
And then the critical, dramatic turning point for our patient, stage 8, plaque rupture or avulsion. The plaque breaks open.
This is the moment when a chronic, stable plaque suddenly becomes an acute, unstable situation. That fibrous cap we talked about in stage 6, which covers the highly reactive, lipid-rich necrotic core, can become unstable.
Why does it become unstable?
Well, it's driven by ongoing inflammation within the plaque, the activity of enzymes like matrix metalloproteinases that degrade the extracellular matrix, basically eating away at the cap structure, and often a thinning of the cap itself. When this cap becomes too thin or too weak, it can rupture. Sort of, yes. This rupture is catastrophic because it exposes the highly thrombogenic contents of the necrotic lipid core, things like collagen and tissue factor, to the circulating blood. Alternatively, a plaque can also undergo erosion, where the endothelial surface is lost without a full rupture, also exposing underlying thrombogenic material. These events transform a chronic, stable plaque into an acute, unstable situation,
Instantly.
initiating a cascade that will be felt very quickly by the patient.
And once that highly thrombogenic material is exposed, we quickly move to stage 9, thrombus formation. This is where option C, platelet activation, finally comes into play right at the end of this long story.
Exactly. This is the acute crisis moment that happened to our patient. The exposure of subendothelial collagen and tissue factor at the site of rupture immediately triggers rapid platelet adhesion and activation.
Platelets rush in.
They do. Platelets, those small blood cells involved in clotting, quickly stick to the exposed surface and become activated, changing shape and releasing more prothrombotic factors. This simultaneously initiates the coagulation cascade, leading to the formation of a fibrin mesh. The combination of activated platelets and fibrin rapidly forms a blood clot, or thrombus, at the site of rupture.
And it's this thrombus that then causes the immediate life-threatening event by blocking the artery.
Precisely. If this thrombus is large enough to completely or significantly block blood flow, it leads directly to an acute clinical event. In our patient's case, an occlusive thrombus in her LAD artery caused her acute ST elevation myocardial infarction, her STEMI.
The heart attack.
Heart attack. This same process can also cause unstable angina, a stroke if it occurs in cerebral arteries, or peripheral artery occlusion. It's crucial to emphasize the time frame here. While the preceding stages of atherosclerosis unfold over decades, from endothelial dysfunction to obstructive plaque, the events from plaque rupture to acute thrombus formation, leading to a heart attack, can happen in a matter of minutes.
Decades to build, minutes to collapse.
That dramatic contrast underscores the silent nature of the chronic disease versus the sudden catastrophic nature of its acute complications. So while option C, platelet activation, is central to the acute event, it's clearly far from the initial pathogenic step. It's a late-stage consequence of plaque rupture.
This detailed journey truly brings everything together, from the invisible cellular changes right up to the emergency room crisis. Now let's talk about mastering these details, because there are some common misconceptions and critical nuances that often trip people up, even those who consider themselves well-informed. Things you might see on an exam, for instance.
Yes, understanding these distinctions is paramount for anyone who truly wants to master this topic. Absolutely. One of those common pitfalls is confusing the initial pathogenic event versus first visible manifestation.
We touched on this, but it's worth hammering home.
It really is. We've discussed it. But it bears repeating with emphasis. Endothelial dysfunction is the initial pathogenic event, the fundamental biological trigger that starts everything. However, foam cell accumulation, which leads to fatty streaks, is the first visible histological manifestation.
You can see it under the microscope.
Right. Fatty streaks can be seen in young people, which often leads to the incorrect assumption that they are the very beginning of the disease process. This distinction is critical because understanding it fundamentally changes how we think about prevention. If we can target and manage risk factors that cause endothelial dysfunction like hypertension, smoking, or high cholesterol, we can intervene long before any visible disease is present.
Way upstream.
Way upstream, potentially preventing the entire cascade before it even gets properly started. That's the power of knowing the true beginning.
And it's not just about what starts it, but understanding the entire sequential nature of the disease. It's a multi-chapter story, not just one event.
Absolutely. Stressing the step-by-step nature of atherosclerosis is crucial. It is not a single isolated event, but a progressive disease where each step builds upon the previous one, like meticulously laid bricks.
Okay, give us some examples of those crucial sequence distinctions.
Sure. For example, differentiate between LDL infiltration and LDL oxidation. Infiltration is simply LDL getting into the intima. Oxidation is what happens to that LDL once it's there, making it inflammatory.
Right.
Or consider monocyte infiltration into the intima, followed by macrophage transformation and then foam cell formation. These are distinct events that occur in a specific order, each enabled by the preceding one.
Infiltration, transformation, formation.
Got it. Similarly, smooth muscle cell migration into the intimae precedes their proliferation and their production of extracellular matrix, which eventually contributes to the fibrous cap formation. Each step is necessary for the next, highlighting the chronological progression of the disease.
Oh.
And finally, understanding plaque growth leads eventually, potentially, to plaque rupture, which then directly causes thrombus formation. These are distinct phases, transforming a chronic condition into an acute, life-threatening presentation. Knowing the order is everything.
It also seems like inflammation is a constant player here, not just an initial trigger, but a thread woven throughout the entire process, keeping things going.
That's a key takeaway. Inflammation is a continuous thread throughout the entire atherosclerotic process. It's not just an initial trigger causing endothelial dysfunction. It drives monocyte recruitment, fuels macrophage activity and foam cell formation, contributes to plaque growth by stimulating smooth muscle cells and extracellular matrix deposition, and critically, it plays a major role in destabilizing the fibrous cap, leading to plaque rupture.
So it's involved at almost every stage.
It is. It's a self-perpetuating cycle within the vessel wall, constantly accelerating the damage.
Yeah.
Managing inflammation is key.
And ultimately, all these intricate microscopic changes have a very real macroscopic impact on the patient. That's what brought our patient to the emergency room in the first place.
Exactly. We must always tie these intricate cellular and molecular changes back to their clinical relevance. The 80% stenosis in the LAD artery that caused our patient's acute myocardial infarction is the direct macroscopic consequence of decades of these microscopic processes silently unfolding within her arterial walls.
Wow.
Understanding this connection helps us appreciate the severity and progression of the disease and why seemingly abstract biological processes have such profound real-world consequences.
So this deep dive truly underscores why managing risk factors like hypertension, diabetes, or smoking isn't just about general health advice. It's about directly protecting the integrity of your endothelial cells, the very gatekeepers of your arteries.
That's it.
It's about preventing that very first domino from falling.
And that's the power of this knowledge. Our deep dive has taken us from an emergency room drama back to the microscopic beginnings. We've seen how the silent, often invisible damage to those tiny endothelial cells is where the story of atherosclerosis truly begins,
We'll start.
setting off a chain reaction that unfolds over decades before manifesting in a sudden crisis. By understanding this entire sequence, from the initial cellular changes to the final acute event, you, our listener, are now incredibly well-informed and have truly mastered this complex yet vitally important process.
What's fascinating here, and maybe a final thought to leave everyone with, is how something that takes decades to build can unravel in minutes, causing such a sudden and life-threatening event.
It's quite the contrast.
It really is, and it raises an important question for all of us. If the origins of disease are so subtle and long-term, starting with maybe just stressed-out endothelial cells, what does that tell us about the hidden power of our daily choices? Choices in shaping our health, protecting those endothelial gatekeepers, even when we don't feel a thing for years or even decades. It's a powerful reminder, isn't it, that every choice we make might have a ripple effect far beyond what we immediately perceive.